right, good afternoon, everyone. It is 1 o'clock on my watch, so I definitely want to make sure we are respectful of your time and we get started. So we are recording today's session and it will be available on our website within a week. So I want to let you know that, and we'll send out a link to the webinar once they have all been uploaded after the series is finished. So I want to welcome you. My name is Tricia Lizumbo. I'm the director of Health Network. We are going to get started. I am going to make sure that I mute everyone, and then I want to remind my presenters to unmute themselves as well. And with that, I am going to turn it over to Jody and to Dan.
Okay, perfect. Thank you, Tricia, and welcome everybody. Okay, we can have the first slide, please. Okay, so my name is Jody Gornflow, and I am the Probation Mental Health Systems Liaison for Oakland Community Health Network. And today we're going to be talking about prevention and diversion, and this will also include Dan Holloway, our Adult Jail Diversion Coordinator. Next slide, please. So we're going to talk about the sequential intercept model, and this is a national model developed by Policy Research Associates that's used to inform community-based responses to cases involving individuals with mental health and substance use disorders. At Oakland Community Health Network, we have used and we continue to use the sequential intercept model in the development of various justice initiatives. And we're going to talk about the first couple of these today. And then our subsequent webinars will talk about the other ones. Next slide, please. So we're going to talk about, we're going to start with Intercept 0, but really quickly, I just want to discuss the sequential intercept model. Providers are really vital partners in the application of the sequential intercept model. The goals of this model are to decriminalize mental illness. We do not want mental illness to be criminal. We want to work to change the social and moral norms surrounding it. We want to develop options at each point in the model. And again, we'll talk about the first two today, and in the subsequent webinars, we'll talk about the others. And we want to divert individuals from involvement in the criminal justice system or continued. So if they have had involvement in the criminal justice system, we would like to divert them from having any future criminal justice involvement. And of course, we would like to engage individuals in treatment anywhere, wherever they are in the community, and also offer supports. Next slide, please. So we work with our internal and our external community partners. That includes you, and that includes everybody else in the community, including all the justice agencies. And we work towards cross-system collaboration, and we coordinate all of our initiatives, which again, we will talk about all of those down the line. We routinely identify people. We use our liaisons to routinely identify people with mental health and substance use disorders that come to the criminal justice system. Oh, can you go back? Thanks. We strive to provide access to treatment, and that is across the board, including co-occurring needs, mental health, and substance use disorders or dual diagnosis. We want to achieve linkage to benefits to support treatment success. And so this includes helping individuals apply for any benefits that they qualify for: Medicaid, Social Security, Medicare. And of course, we always want to achieve ultimate information sharing. We want to be able to share information that helps with care coordination. And we have performance measures across our systems and across all providers. And that includes data collection, analysis, and then sharing for optimum outcomes. Next slide, please. So we're going to start with Intercept 0. And Intercept 0 focuses on crisis care and crisis management in the community. It's really about prevention. And hopefully you're all aware of crisis services here in Oakland County, but we're going to talk about them right now. So one of our crisis services includes Common Ground. It is a 24-hour walk-in and drop-off center. It has the 24-hour crisis line, which includes text and chat. It's also where individuals are assessed for inpatient hospitalization criteria. And it's where the petition and the involuntary psychiatric admission process takes place. The petitions can really come from anywhere. They come a lot from the community, but they can come from probate court, Oakland County Jail. They can come from law enforcement, police, the sheriff's department, any of our providers, family members, really any members of the public. We're going to talk about crisis services and our mobile crisis services. We have OCIRT, which is the Oakland Crisis Intervention Response Team, and ICSS, which is the Intensive Crisis Stabilization Service. And these mobile crisis services, they can be incorporated into each individual's crisis plan. This way, individuals are familiar with the services that are available, and also their support people and their family members are aware of the services that are available when it comes to mobile crisis services as well. One of our community services is obviously the emergency department, and there are reasons why individuals might prefer a local emergency department, even though we do have ground. Really a jewel in our community, but there are individuals who might prefer to go to the emergency department, and this could be multiple reasons. There could be proximity issues. It could be wherever they're staying or wherever they're at the time that the crisis is happening. They might not be at their home base. They might be at a family member's or a friend's house. And so the emergency department might just be closer. Or also in situations when individuals have integrated health needs. So if they also have physical health needs and they know that their physical health needs are in jeopardy at the time as well, they might prefer to go to the emergency department where they have access to a medical team as well as a psychiatric team. And lastly, the intensive outpatient supports through your agency. So for an example, the ACT team. So you might have an individual on your caseload who just needs more intensive services, either based on what you observe or what you're told by people that are involved in that individual's case, like family members or probation officers, or maybe there's staff in your agency that has witnessed certain behaviors, whether it's in the lobby or maybe it's the nurse. That ACT team, as you know, can offer sort of that more early intensive support for psychiatric stabilization. You know, it can also be an option if an individual has frequent hospitalizations or more intensive supervision and support needs. So it could be really useful in avoiding those frequent hospitalizations. Next slide, please. So the crisis care continuum, we're going to highlight some of the roles and services within your agency, and we're going to start with the crisis plan. So obviously the crisis plan is one of the very basic functions of working one-on-one with individuals, and it's also a critical step in aiding individuals in avoiding either initial criminal justice involvement or continued criminal justice involvement. It's really important that after the plan is made with the individual and also all of their supportive people, that you review it regularly with them and that you make any necessary updates and changes along the way. And the reason why it's important is because reminding an individual of their own crisis plan regularly can reduce that uncertainty or that insecurity of knowing who to call, where to go, or what to do. As we know, and we've heard multiple times, you need to hear something or be taught something a minimum of 7 times before it becomes ingrained in your thinking or it becomes a habit. And so this is kind of the same thing, which is we just need to make sure that we're reviewing an individual's crisis plan with them regularly so they know exactly what to do if they find themselves in a crisis situation. I think it's especially important with group home residents. It's really necessary that all of their supportive players are involved in that plan. And you might find yourself having to keep in regular contact with group home staff so that they know exactly what's in each individual's crisis plan, because we want group home staff, and Dan's going to talk about this a little bit because this is one of the frequent contacts that he gets. We want to make sure that the staff at the group homes, that they implement the plan that has been set out in the crisis plan before they call law enforcement. So the second critical step is really barrier removal. It's important to be aware of community resources that are out there to support you in helping individuals, and also just for the individuals to contact or make contact themselves. So here we use the example of homelessness because obviously we know it's very pervasive among individuals with serious mental health needs. And as we talked about earlier, when we put up the sequential intercept model, that slide, our efforts and initiatives really around the sequential intercept model, homelessness is definitely a focus for us because it's so prevalent in our community. We want to help decriminalize homelessness. And this is a view that we all, and a belief that we all hold working in the mental health field, which is being homeless just should not be a crime in and of itself. So we need to always be helping individuals and assisting individuals reduce the barriers that they face. It could be housing, it could be employment, it could be transportation, or perhaps food insecurity. So we just encourage you to consistently address the basic needs of your individuals that you serve, because when people get their basic needs met, we know that they commit less crimes connected to those deficits. So like some of the crimes that people commit when they don't have food and they don't have shelter and they don't have anywhere to go are things like trespassing or loitering or retail fraud, which is also known as shoplifting, or perhaps disorderly conduct. So the next step is stabilization, and all roles within your agency, they really play a part in this step. It's achieved by a variety of methods, stabilization is. Obviously, psychiatry and medication compliance. This is a vital step. So as an example, if you have an individual who's med compliant and they're otherwise stable in some of their other life domains, they might be able to better maintain employment. So the more life domains that we can achieve stabilization in, the better the outcome will be. You can always also, not always, you can also achieve this through consistent therapy. Some individuals don't need to take medication. Some individuals might need a combination of both. And as we discussed with crisis planning, helping individuals secure their basic needs can definitely lend significantly to stabilization. So again, we always want to make sure that the removal of barriers and the basic needs, we're always working towards that, because that's a big part of stabilization as well. Now, for those who seem to always be sort of teeter-tottering between stable and crisis, it might just be necessary to continue to examine more intensive or increased supports along the way, and that could be services such as ACT. Um, some individuals just have continued intensive needs, and it's okay to continue to explore those situations and those treatment options. There are also those individuals who may have areas of their life where stabilization just is rare, or maybe it'll never happen. But the more positive strides that they make towards stabilization in their other life domains, or even that domain, we know that the better the outcomes will be, because any falter in overall mental health and substance use stabilization can lead to criminal justice involvement. And that is the whole point of what we are trying to help avoid, is criminal justice involvement and further criminal justice involvement. And the last critical step that I'm going to discuss is system navigation. And this is really just continuing to work towards obtaining individuals' basic needs. Do they want or need to apply for Social Security? Do they have enough food to get through the month? Have they been connected to community housing network if they're at risk of homelessness or they're looking for more permanent housing solutions? Do they need help finding a primary care position? A really helpful service when it comes to system navigation can be peer support through your agency as well. And peer support specialists, they really provide that additional support and system navigation, they can utilize their own experiences as well. And I think that that's really important when it comes, and there's a lot of research about peer support and peer support specialists really benefiting an overall treatment plan for individuals. And honestly, a lot of peer support specialists have had their own criminal justice involvement. So they can use what they've learned by navigating the system to sort of inform their own work, their own one-on-one work with individuals. Next slide, please. And lastly, before I hand it over to Dan, we're going to talk about the release of information, about information sharing and why that's important. So information sharing and having a release in place is really vital in ensuring that there's no gaps in communication between interested parties on a case. This could be the difference between getting an individual the help that they need and not being able to get them the help that they need in the moment because of HIPAA or 42 CFR. It's really crucial in crisis situations, especially. And a lot of times, logistically, that doesn't seem possible. And we'll talk about sort of planning ahead. But if it is possible to do before the crisis situation arises, it can be really helpful when it comes to care coordination. So, having that release of information should be part of all case planning. It really goes hand in hand with the crisis plan, like up front as well. It ensures that all parties involved can share information like social workers at the hospital, or psychiatrists, or primary care physicians, group home managers, probation and parole officers, really any interested parties when it comes to an individual's case. So, if you know that an individual is trying to get into a group home, or you have someone, let's say, that's in the jail, or you know that an individual is on probation or parole because when they come in for their initial meeting or their intake, that they have told you, it's important to like think ahead about including those entities on the release of information, because that can absolutely benefit the outcome on the case, especially for individuals that are going to go further with criminal justice involvement, and for those who are going to be having charges filed against them and that will be going through the criminal justice process. And I just want to stress and just to say and remember that information sharing only benefits care coordination. So not only does it benefit the individual, but it also benefits you. It benefits the job that you're able to do working with an individual. I wanted to quickly touch on a specific situation, and that's emergency departments. So even though individuals are supposed to see a social worker prior to their discharge for psychiatric visits, that just doesn't always happen. So if you know, for instance, that an individual utilizes a particular emergency department regularly, you might want to just include that hospital, that department in the original case planning release of information so that you can stay apprised of any developments in that individual's case. Or if you want to share relevant information prior to their discharge from that particular emergency department, it takes a lot of forethought when you're making the case plan. But at the same time, if you can get permission and you can add these things to the release of information, the only person, the only two people really that benefit are both, the provider benefits and the individual benefits. And in the end, outcomes are what we're working towards. So lastly, in regard to the release of information, I just want to mention, and again, we'll talk about it in subsequent webinars, but we have various justice liaisons embedded at numerous locations around the county. And so some of our liaisons are at the jail, community corrections, at the circuit court, adult treatment court. And those release of information, they're always beneficial to care coordination. So we work really closely together, and we utilize those release of information when they're on file. They really help us in the care coordination process for individuals that are involved in the criminal justice system. And, since we're the PIHP, we're included in those ROIs. And so you might be receiving calls. Some of you may have already received calls, but you may be receiving calls in the future from a liaison who is just trying to provide you with the information that you need about an individual on your caseload. So for instance, I get calls or I get emails about individuals that are arrested and that end up in custody or potentially that end up in Oakland County Jail. And what will happen is the pretrial service officer will email me or they'll call me and they'll say, this person is here. So what I do is I look them up. I find out who their case manager is, who their therapist is, and I make a phone call to alert them of that situation. And hopefully that's very beneficial. And I've been told, obviously, that it's very beneficial to know, because if you're there and you haven't talked to your person for a week or even 2 weeks or whenever the next appointment is, it's helpful for you to know why your individual hasn't responded to calls, or maybe where they are in the community, or kind of just what's going on. And it, again, it only benefits care coordination in the end. So our next presenter, he is going to talk a little bit more about the release of information when it comes to diversion. And so he'll discuss that a little bit further, and he'll discuss, the care coordination process on that end. So at this time, I'm just going to go ahead and hand it over to him. His name is Dan Holloway, and he is our jail diversion coordinator. Dan?
Yes, thanks. Good afternoon, everybody. Nice job, Jody. Tricia, I am not seeing the slides as they're progressing through. I'm still on the webinar code of conduct on my screen, but I do have the PowerPoint pulled up on a different tab. So I think we should be okay, but I'm not sure if there's anything that you can do about that. But like I said, I still have the PowerPoint right here. So starting off on slide 10 here is the Intercept 1, which is law enforcement, and that's actually right where pre-booking jail diversion efforts kind of take root, and that's kind of what we've been developing for the last really about 18 years. It's been a long time in the making, but with a county our size, it really took a lot of effort, a lot of teamwork, a lot of involvement from stakeholders throughout the county. And so I remember back in the day when we were, I got hired for this job, the jail diversion coordinator, and we just realized we needed to start looking at other models that were out there around the country, and sort of rounding up stakeholders, law enforcement, judicial staff, community corrections, advocacy groups played a key role. Of course, our core provider network representatives. Like, we just started to build this jail diversion advisory team. And again, our first steps were researching what is pre-booking jail diversion. We knew it had recently, in fact, it was 1996, been written into the mental health code. So we knew it was like a mandate that we had to build some type of initiative, some type of options for law enforcement to have in the community. So when they encountered, as Jody said, when they encountered people who were committing low-level public nuisance types of offenses, or just when police would encounter citizens in situations where they just figured it may lead eventually to criminal charges, so that it's not like police have to sit around and wait till they witness a crime. They're being, as the programs evolve, they're being much more proactive and preemptive and linking people with services just because they've had a call or a complaint from another citizen. So we started looking at other models. We realized, like, the gold standard was crisis intervention team training. That is what drives, that's like the engine that drives these pre-booking referrals from law enforcement. We knew that was a major undertaking. Back in the day, we just started building any type of cross systems collaboration and any type of training, very basic sort of training materials that I would take out to law enforcement agencies and just introduce the concept to them. Say, you do have this in the mental health code. You do have this this leeway in this gray area to use your discretion. And here's what our system looks like. Here's how we can help these citizens. Here's how we can reduce the number of calls, repeated calls to the same citizens and same residences that the law enforcement is dealing with. So It is exactly as the name implies. It's no charges. We want to bypass the criminal justice judicial system altogether. Of course, the correction system. We want to get these folks linked up with services right from the community. So again, we knew we didn't sit around and wait for funding and for grant dollars, because the CIT, the Crisis Intervention Teams training, is costly and it is a massive undertaking. And I'll talk more specifically about that because we've had some good success in the last 5 years with those. But we know we needed to just get our foot in the door and get conversations happening and get leadership on board, law enforcement leadership, community, county commissioners, the prosecutor's office. So we started building the dialogue and building these alliances, and even just figuring out the communication that our systems were using. We needed to just get on the same page. So we started developing some smaller trainings, and that has evolved over the years to include dispatcher trainings. We've got crisis intervention teams trainings. I mentioned that we've had 5 of those, if I'm not mistaken, and we've got another CIT training coming up here in a couple weeks. But that's just amazing to get law enforcement in the room. We get 40 hours to bring in a whole team of trainers, both from our provider network, from all around. We get experts from a multi from anyone we can round up who has an expertise in related subject matter. And so we've built this training over the years. It's really amazing to see kind of this ideological shift, how I guess I would describe it, that happens throughout the course of that week. And we've gotten real good feedback. And one thing that's worth noticing too, or worth mentioning, is that we noticed the number of diversions that were being taken to common ground, because that's a common option, popular option for police, is to go right to common ground with citizens. We noticed the number of those being taken to common ground doubled that first year that we did the CIT training. And that was what we hoped. That's what we had been building for. And it's really been paying off for us since we launched that back in, I think it was 2015. So the other training that's evolved, we know it's a challenge for police agencies to devote their manpower to a full week training. So mental health first aid is a training that I'm certified in myself, along with Deputy Chief Ryan Gagnon from Auburn Hills Police Department. We went and got trained for a week-long training to become certified trainers in that, and that's been successful too. We've had 16 of those trainings, and that's an 8-hour training. So that's a little easier for police agencies to devote manpower to. They do get like a certificate that shows that they that training. And we just think it's important to offer both of those trainings. They both have similarities for sure, similar goals. They both really put a focus on officer and community safety, and increasing access to treatment and to services. Those are kind of a couple of the main pillars. And one thing too that I really enjoy and that I've learned so much about is both of them have a real focus on officer wellness. And so that's a really important thing when you get that many first responders in a room, and you're actually, they let their guard down and they start talking about their critical incidents they've been involved with, and sort of the stress of their first responder roles. And so my co-trainer and myself, we make sure, and the curriculums themselves really place an emphasis on officer wellness and making sure that they're taking care of themselves and looking out for themselves. And that's been pretty cool too, and to learn more about the supports that are available and the groups all around the country that assist with that. And then the last bullet on this slide, the police drop off to common ground. That's important too. As other communities are learning, we've helped, I don't know, a dozen or more communities launch similar efforts in their respective areas. And if they don't have a designated drop-off, a 24/7 preferably drop-off location, it's even more challenging for police. But especially with a county our size, we know we needed to have something like that. And the RCC program, they're embedded in Common Ground. The staff there do an amazing job and have really built trust and built a good working relationship with law enforcement. It's worth mentioning too that police don't exclusively use that location to divert people. Police, another cool part of this is the evolution and the creativity, I guess, of law enforcement is they are diverting folks and linking them to other types of human service agencies directly. They kind of are getting to know more and more about what Common Ground does and what our system does and the agencies within their community, and they're making like sort of direct referrals, or at least, or actually more accurate to say that they're giving out resources, and those citizens are connecting with providers, with different services. We do I think a pretty good job of making sure we have plenty of resources during these trainings to hand officers, the resource and crisis helpline, the access number, substance abuse services, all that kind of stuff, housing. We all are starting more and more, and this has just been happening, again, like I would say in the last 5 years, a real focus on this is equipping those officers with the information they need to distribute that to citizens directly in the field. So we've been pleased with that. And the more trainings officers get, because I've had, I know officers have gone through CIT and mental health first aid. So when they're called to a scene, they're like the officer in charge at that scene, and they're familiar with the system and the services and how to access them. So that's been really cool to see that happen too. And if we could switch to the next slide now, which should be slide 11, adult jail diversion coordinator responsibilities. This is kind of what I've already been mentioning, but what I've been doing for these years of this being a training resource. In addition to those trainings that I mentioned on the previous slide, I routinely go out to the police agencies and do, like mental health resource presentations. Sometimes it's 1 hour, 2 hours, whatever however I can get on their training block. I'll do that at the police agencies and also at the police academy itself. And then, of course, our overall goal is to advocate for individuals. It's about accessing services. Sometimes these folks who are being diverted and officers are encountering, sometimes they're already linked up and they're just inactive in our system. Sometimes they are active, and sometimes they're new to our system. So wherever they happen to be at, the goal is to get them linked up in services and hopefully kind of interrupt some of these self-defeating kind of patterns and cycles that folks can find themselves in. So the next slide here is slide 12 is the jail diversion mental health code. I mentioned this was implemented in Michigan in 1996. This was important too, and I share this with officers during our trainings, and it's important that they know what like the legal underpinnings are for their discretion, especially if someone has committed a criminal offense, and this gray area that allows them to utilize services, treatment and service options instead of charging folks with a crime. Letting them know, and this was, I remember going back and really having to meet with police agencies and help them build their policies, because those early trainings officers would say, wait a minute, I don't have that authority. If I see a crime and witness a crime and there's a complaint from, let's say, a business owner or another community member, like we have to hold that citizen accountable. And the mental health code allows them to tap into other services and think outside the box. And so that's kind of actually still a work in progress, is helping these agencies modernize their policies so that the patrol officers and the shift sergeants feel like they're supported by their agencies, in making these types of judgment calls in the community. And so the next slide here is just more information on what pre-booking diversion is. And this is an important disclaimer too, is that it is officer discretion. So it's up to them. That's why training is so important. That's why policy is important. That's why leadership within the law enforcement community is important, because they're making these decisions out there. Sometimes just snap decisions based on their communication with that person. So a lot of what we do in our trainings is teaching de-escalation techniques and strategies, and making sure there's a good dialogue and a comfort level, and making sure the officers are comfortable with making that decision, because knowing that our system, and this is another adjustment that law enforcement had to make, sort of just ideologically, is making the decision to know that you're going to refer someone into our system, and our system is voluntary. So it does happen from time to time that these officers have all the best intentions, put forth their best efforts, use their training, and that citizen doesn't follow through on treatment once they're referred. And the way that it works here in Oakland County, and most other counties that I'm aware of, is there's no hammer that comes down on those folks. This is why it's such an important partnership with law enforcement, is they're trusting our system to do outreach, to continue to try and engage the person. And that's what I spend a good amount of time doing too, is trying to convince these divertees that it's a good, and not just me, obviously, anyone that they come in contact with our system, but this is an opportunity. And what officers have told me is they're like, we get it, we'll refer them. These are low-level misdemeanors. If there's no threat to public safety, we're willing to do this and give them the option and the opportunity to address their treatment and service needs. But if they encounter them 2 or 3, 4 times, that's no longer going to be an option. That's played itself out to be the case. But we have a pretty good track record. Our system as a whole does is, over 80% of the folks that get diverted end up sticking with treatment at least for 60 days. I typically will follow a case 60 to 90 days. So we've got a good track record with that. So charges involving drugs and alcohol, that's very, very rare, but I thought it was worth putting in there. There has been small amounts of marijuana, open intoxicants in the community, that type of thing. But the program really, or the option really, isn't designed for that. It just happens to be that, that doesn't make someone necessarily ineligible, because we want to help if they happen to have those substance abuse needs as well. Wanted another crime, that's another one that's rare. Officers will kind of run their name in their system, and if there's a warrant out for them, they're still going to hold them accountable for that warrant, but whatever new charge they may have, I've learned over time that they're not submitting new charges. Non-Oakland County residents are eligible. That happens on a somewhat regular basis, and always has. And in that case, if they are taken to Common Ground, then Common Ground just starts coordinating with their home county, their county of origin. And persons meeting commitment criteria, that just happens too if there was criminal charges involved during the petition and commitment process. Officers, again, it's almost like a semantics scenario here, because we really are just looking to decriminalize these runs that these officers are involved with. And as long as they're not posing a threat to another citizen or to, society in general, officers are having more and more faith and more confidence and knowledge about our system to where they're willing to do that. And the next case, or the next slide, please, number 14, pre-booking diversion. Just some more, kind of like a summary really on this slide, but it's like I just mentioned, it's decriminalizing calls involving a person who may have a mental illness, a developmental disability, or substance use disorder, or all of the above. It is, again, it's an option for officers. It's another tool for their tool belt. I get quite a few calls from family members, advocates, relatives of somebody, and they're saying we're requesting a pre-booking diversion. We want to know why the officer didn't, and it just goes back to, again, without being there on the street and knowing what that conversation is, because officers, again, it goes back to, they're trying to gauge whether someone is right for this. This isn't for everybody. This pre-booking option isn't for every situation. So the officer's engaging in a conversation. They're trying to get a sense of whether that person is receptive to treatment. And if they're going to follow through, if they do give them resource information or transport them to common ground or link them up with any kind of healthcare provider or homeless shelter or wherever, whatever the officer's efforts are going to do, they're gauging whether or not the citizen is at a place and time where they're going to follow through on that. And knowing that they're not going to get it right every time, but that's part of the evaluation that officers are making right in the field when they're trying to decide whether or not someone is a good candidate for a diversion option. And with that is the information I wanted to cover. And I think I'll kick it back to you, Tricia, and we'll be able to answer any questions.
Great, thank you, Dan and Jody. I'm going to leave this slide up for a little bit, but we can open it up if you have any questions. I did put a few links within the chat that kind of corresponded with what each speaker was discussing, but we'll open it up for any questions now. Feel free to unmute yourself or use the chat. And if we don't have any questions, again, this is being recorded and we will have it up on our website within a week. And then once the series is completed, we will email out the link to everyone.
Dan, what level of mental health training do you feel is, like, where do we find the balance between providing mental health information for law enforcement officers and sort of going down that rabbit hole of turning them into mental health professionals? What level of training do you think is appropriate? What's that happy balance?
That's a good question. My first reaction is to say the more the better, but that's not realistic. What I've seen shift in the last, especially for maybe 3 to 4 years, is that I used to go around and it was hard for me to get my foot in the door. Chiefs and command staff had their own training mandates. And their training budgets are a little bit restricted. And now they're reaching out to us, and I'm getting more and more calls for more training. So I would think at the minimum, here's what I would like to see is that if every police agency has, let's say, 20% of their workforce that has either CIT or mental health first aid training. So the crisis intervention teams training, the 40-hour or the 8-hour mental health first aid. If we could get, well, here, let me go back a second. Actually, what would be great is if 20% had the CIT training and 100% had the mental health first aid. That's what I would feel, that you've got some that are a little more sort of, I don't know, not experts, but more in tune with and more intensely trained through the CIT option, but then that the basic training for all officers would be that mental health first aid, which is the 8-hour training. Does that answer your question?
It does, yeah.
Yeah.
Do we have any additional questions for Dan or for Jody? If not, then I'm going to give everybody some more time back in their day. Again, thank you so much for joining us. We will be having our next presentation. I don't have it pulled up, but next month, Dan, if you know the date, in November, we will be having our follow-up, which will cover Intercept 2 and 3.
November 13th.
Perfect. Thank you. And then December 10th, I believe, is the last one that will cover Intercept 4 and 5. So with that, I want to thank you guys very much for attending and have a wonderful week.